Hey guys, good evening and welcome to the second part of this top 100 images series that we're having for the FMG aspirants. What we're going to do now is look at 10 images again which have featured very frequently in your exams. So 10 images at a time every day, 15 minutes, just invest 15 minutes of your time and hopefully it'll yield us direct questions in the entrance. So just give me a quick confirmation if I am visible and audible to you all. My name is Zainab and I've done my MBBS from AIMS followed by MD and Senior Residency in Radiology. So let's begin. Unacademy, download the app, and if you're interested in unlimited classes by all the educators, get Plus subscription and you can combine it with Prep Ladder to get iconic subscriptions. So I'm just gonna shout louder if the voice is low. Do use headphones, that would help probably. Okay, so these are the special classes which are free classes that we are gonna have. These are the offers on subscription. So 24 months you get 4 months free and 12 months you get 2 months free, and you can use my code which is ZVURA in order to get additional 10% off. Okay, these are the various batch courses which are ongoing. So once you get the subscription, you can definitely choose the batch depending on your exam of interest. I did post the PDF on the group, on the radiology group, Bhavya and Dr. AV. So you can get it from there. Radiology with Dr. Zainab Bora Telegram group. You'll find the PDF, alright, so that you can make notes simultaneously, because I know my handwriting is terrible, and simultaneously you can make notes. So the first image that is very important, which is an integration of radiology and anatomy. So they can ask you radio anatomy like this. This is how the future exams are going to look like, where it won't be just one subject, maybe as many concepts as possible which will be tested at the same time. So both of these images that I'm showing you here are MR angiography images. How we know it's MR angio is you're seeing that the bones here are not white, they are all black, and we have blurred out the background. Alright, so this is how an MR angiography image will look. So one is an axial section at the level of circle of Willis. This is a coronal section. Alright, so both of them are actually demonstrating the circle of Willis. Let's have a look at one image at a time. Let's look at the axial image. Okay, anybody can tell me what the yellow arrow here is showing? What are these two vessels which are going anteriorly? So these are anterior vessels. These are anterior cerebral arteries, right? So this is ACA, which are communicated by ACOM. Alright, and this is probably the most common site, right? So do you remember that MCQ? This is the most common site wherein you have berry aneurysms which get formed, alright? So ACOM ACA junction is where we have berry aneurysms. On the other hand, the vessel of ICA, which does not take part in the formation of circle of Willis, going laterally in the sylvian cistern and then giving off these cortical branches, is middle cerebral artery, right? So here we have middle cerebral artery, not a part of circle of Willis. Here you can see the curved ICA on both sides, right? So this is the internal carotid artery which is forming the circle of Willis by giving rise to ACA, and posteriorly one more small branch is given off by the ICA, which is gonna contribute to the circle of Willis. These small branches here are gonna be posterior communicating arteries, right? So remember, PCOM, a branch of ICA again. On the other hand, when we go to the posterior circulation, what are we having? I'm having these two branches which are arising from the basilar artery, right? So here I have the single unilateral basal artery dividing into the terminal branches by red arrow, which are posterior cerebral arteries, PCA. So together, this is how the circle of Willis is formed. ACOM, ACA, ICA, PCOM and PCA. Alright. On the other hand, when I give a look at the coronal image here, when we look at a coronal image, again pretty similar. So if I have to highlight what is this vessel here, it's having this course which is having this curve, this is ICA, right? So this is the internal carotid artery which is giving rise to the two terminal branches again. So laterally the yellow arrow showing MCA and yahan pe ACA, right? On the other hand, if I use the highlighter, what do we have here? What are these two branches which are coming from the posterior circulation? These are vertebral arteries, right? So dono vertebral arteries, combining to form basilar artery, dividing to form PCA, right? So pretty simple, not very difficult, the same anatomy, right? So difference between axial coronal view, it's the view. Axial is a transverse section, whereas coronal is looking at it up front, right? So we are seeing a coronal view here. Can you see one more thing marked by this light blue color here? Just before PCA, there's one more branch which the basilar artery is giving. Can somebody tell me what is the blue arrow showing here? This part here, which is this branch. Very important. This branch here is the superior cerebellar artery, right? So this is superior cerebellar artery just before giving rise to PCA. Okay, and this superior cerebellar artery and PCA, there is one nerve which courses in between the two. It is the third ophthalmic cranial nerve, oculomotor cranial nerve, that you need to know, the third cranial nerve which can get compressed by an aneurysm of any of these, right? So third cranial nerve getting compressed between superior cerebellar and the PCA. Okay, so this is about the anatomy. One more time just to make it easier. So posterior circulation, vertebral artery giving rise to the basilar artery as a single midline vessel. Here we have the ICA which arises. Basilar artery will give rise to pontine branches, superior cerebellar, PCA, and this is where we have the third cranial nerve. ICA giving rise to PCOM, MCA, ACA, and ACOM. Right? Is this clear? Everybody, circle of Willis anatomy, whether they ask us on schematic image, theoretical image, or they ask us MR angio, we should be clear. Okay, so this is about that. Yes, iPad is charging. Don't worry, it's connected, so I don't think it will run out of battery. Now from artery, let's go to vein, dural venous sinuses. What is this image? First of all, bones are white. This is CT. So this is a CT or a contrast enhanced CT which is showing the veins. So can I call it CT venography? Yeah. So this is a CT venography image. Tell me the image marked A. What is the sinus which runs on the top of the skull? What is this? This is superior sagittal sinus, right? Just parallel to it by the image marked, arrow marked E. What is that? Parallel to SSS, below it, so inferior sagittal sinus, isn't it? Now, here I have deep veins. What are these two paired deep veins that I am having here marked D? ये कौन सी veins है जो thalamostriate veins? They are collecting the blood from thalamus and basal ganglia and forming internal cerebral veins, right? So these are internal cerebral veins that you are having. The two ICVs will combine to form what? What are they going to combine to form? That vein which can get aneurysmally dilated. जिसका precursor gets aneurysmally dilated. This is vein of Galen, right? So this is vein of Galen. And vein of Galen, when it combines with inferior sagittal sinus, तब वो क्या बना रहा है? What is the structure marked C? It forms straight sinus, right? So ये है straight sinus which is all accumulating here at confluence of sinuses. All right, is this clear? So superior sagittal sinus, inferior sagittal sinus, two internal cerebral veins, vein of Galen combines with ISS to form straight sinus. At the confluence, remember we have four dural venous sinuses. You can remember it as TOS. कौन से चार साइनसेस मिलते हैं? दोनों तरफ से आता है ट्रांसवर्स साइनसेस. Bilaterally, I won't see it on a sagittal image, I'll see it on an axial image. पीछे से एक छोटू सा sinus comes, which is occipital sinus, right? So occipital. S for straight sinus here, and one from the top, which is superior sagittal sinus. Got it, everybody? So this is how the dural venous sinus anatomy can be tested for us. Okay, so this is CT venography. One more very important image for FMG entrance that is asked very frequently. T2 weighted MRI. Water is white, bones are black. T2 weighted MRI image at the level of basal ganglia, at the level of lateral ventricles. What is the first red arrow showing, guys? What is the first red arrow showing? These two horns here. We have the frontal horns of the lateral ventricle, right? So these are frontal horns of lateral ventricle. Behind, what are these two horns? Oriented posteriorly. So these are occipital horns of lateral ventricle. What about the blue arrow? What is this midline ventricle? This is The third ventricle, isn't it? So this is third ventricle, and this area becomes foramen of Monro for us. Okay, so this is as far as lateral ventricles go. Now going on to the basal ganglia, what do we have here? Bordering near the frontal horns is the head of caudate. So the white arrow showing us the head of caudate nucleus. Pathology where caudate nucleus undergoes atrophy. What is that pathology? And tell me the trinucleotide repeat if you can. So we have Huntington's chorea, right? So Huntington's chorea will have caudate atrophy. What is the trinucleotide repeat? It's CAG. And what is it the area? Is it the coding area or the non-coding area that gets repeated in CAG? So remember, all CAG areas are coding, right? All CAG areas are coding, whether it's spinocerebellar ataxia, spinobulbar ataxia, all of these diseases are going to be coding. Everything else is going to be non-coding. Non-CAG repeats are non-coding. Remember that also. Okay, coming back to the anatomy. What is this nucleus here marked by the yellow arrow for us? This is the lentiform nucleus, which has two parts. So this will have outer putamen, inner globus pallidus, right? So this is our lentiform nucleus. All right, so multiple times asked, lentiform nucleus. And finally, bordering on both the sides, marked by the green area on the third ventricle, we have the thalamus. Okay, what about the white matter bundle? This white matter bundle which is connecting the two sides of the brain, this is corpus callosum as an axial section. So this becomes the anterior part. So this is what? This is the rostrum, and this here is the splenium. So we have the rostrum anteriorly, the splenium posteriorly. Okay, so this is what we have, T2 weighted MRI. Okay, right. So this is about the basal ganglia anatomy. Okay, what about this? What do we have here? This is an ultrasound. This is an antenatal ultrasound that we are seeing. And what we have, so the day we don't have admin to control, wait. Okay, I am also trying to report, but anyways, let's see. I don't have that power. Somebody from Unacademy needs to come. All right. Anyway, so this is an antenatal ultrasound of the brain that we are seeing. And what is this? What are the two signs that we are seeing? So here we have bifrontal depression that we are seeing. This happens to be lemon sign, right? So this is the lemon sign. The skull looks like a lemon. Okay. On the other hand, when I show you the cerebellum of this patient, it will be pointed. They won't ask you to identify. The cerebellum looks like a banana. So this becomes a banana sign. So lemon banana sign, antenatal ultrasound, what does it suggest? Options they'll give you in the exam are anencephaly, Arnold-Chiari malformation, Dandy-Walker malformation. What do you want to choose? Which out of these three do you think we'll have lemon and banana sign? So yes, one very big misconception I would like to say, or something which is not the perfect answer, is when they teach you it's spina bifida. Remember, spina bifida is a very non-specific term. All right, it means that the neural arch is not fused. All right, so whenever the spinous processes are not fused, that is called a neural tube defect or a spina bifida. It in no way represents what else is going on in the body. Alright, so the correct answer here is definitely not anencephaly. ये क्या है? अगर anencephaly है तो what is this skull? What is this cerebellum? So it can't be anencephaly कि brain ही नहीं है. This is a brain that you are seeing. This is seen in Arnold-Chiari. So the intrinsic pathology in Arnold-Chiari spectrum is what? It is that posterior fossa is very narrow. There's a lot of congestion, lot of compression going on near the brainstem. All right. So at the cervicomedullary junction, basically, it's all very narrow. So that is why the brain is under a lot of stress. Everything is getting pulled down into the spine. So that is why cerebellum becomes banana-like. Here you have depression because something is pulling the brain inferiorly. Okay, is this making sense, everybody? So this is Arnold-Chiari. It's not related to Downs. All right, meningococcus, it's not related to Down syndrome. This is spina bifida is something that is sometimes given in the options. So if you don't have Arnold-Chiari, mark it, but it is not the correct answer. Okay, so this is about that. Going on to the next image. Again, an easy spotter, a skull spotter. Yes, both the signs are same pathology, both for Arnold-Chiari. Okay, ठीक है. What is this that we are seeing here? In the skull, I am having multiple lytic lesions. It looks like किसी ने punch किया है skull को. There are multiple punched out, or it looks like it has rained down the skull, punched out, or raindrop skull, which is a frequently seen manifestation in two diseases. Wonderful. One is multiple myeloma. The other one can also be lytic metastasis, isn't it? It can also be lytic metastasis. Any way to distinguish? Very difficult. Both are possibilities. Although, if you see कि mandible, इसमें तो दिख नहीं रहा, but if they tell you that mandible also has lytic lesions, then it goes in the favor of M for multiple myeloma. Okay, so this is how punched out lytic lesions will appear. Remember, few other manifestations, few other lytic lesions that you are all saying. I'll just clarify how to distinguish. So these are pretty big, well discernible lesions, right? कि दिख रहे हैं बड़े बड़े lytic lesion. If I show you very tiny, very छोटू lytic lesions with a few white lesions also, when we see कि यहाँ पे resorption हो रहा है. It is not just lysis of the bone. Bone is getting eaten up by the two trabeculae. What is that छोटू like salt and pepper? So this is salt and pepper skull seen in hyperparathyroidism. On the other hand, if you see a child who's having a large geographic lytic lesion with a beveled margins, two margins I can see, that is LCH. Alright, so see the history, see the size of the lesions, and all of these 3 DDs you will be able to distinguish. Got it? Next one, again a very classical spotter, FMG ka favorite. When I see that the trabeculae are raised like this is suggestive of, again, a lot of hematopoiesis, which needs to happen in cases of hemolytic anemia. So this has been described perfectly as an hair on end, although these are not hair, these are bony trabeculations which are raised, also called as screw cut appearance. Both of these seen with hemolytic anemia. They can give you sickle cell in the option, they can give you thalassemia in the option. Okay, so hair on end, screw cut appearance. Fine. Next image. So now from neuro going on to respi. What are we seeing? Again, a favorite exam question. All of these 100 images, we can't go without knowing them. Okay, what are we having here? So what is this part of the chest x-ray, guys? This is called as the CP angle, the costophrenic, between the diaphragm and the chest wall, costophrenic angle. The moment it is not sharp, the moment it is blunted, it means it is pleural effusion. ठीक है, so this is pleural effusion, and if you see कि blunting नहीं हुआ, it has reached the top and it's having this meniscus. If there is water in the cup, see this, if there is water, how is it gonna, free water is gonna go like this, right? It's gonna have this sort of a margin. So this means that there is free effusion, right? So this is suggestive of pani in the pleural space. This is free pleural effusion. On the other hand, if the effusion is loculated, it won't be free like this. It will look something like this. Okay, so this is how a loculated effusion will appear, or an empyema will appear, which has adhesion. It is not free. वहाँ पे कुछ ना कुछ adhesion है जिसने इसको बांध के रखा. Okay, so this is meniscus sign, or as you are all correctly saying, also called as Ellis's S curve, right? So nobody is missing pleural effusion. Can I say that this is pleural effusion, this is hemothorax, or this is chylothorax based on the X-ray, or all of them will look the same? All of them will look the same, right? So on ultrasound, I cannot, on ultrasound or X-ray, I cannot distinguish any type of fluid, right? I can say if it is pus, but apart from that, I cannot say if it is blood, if it is chyle, or if it is just plain old water, right? All of them will look the same on X-ray as well as ultrasound. Okay, so this is not right, Sean, this is left. All right, so remember, all imaging modalities, always imagine it's a person standing opposite to you. This is right, this is left, this happens to be left pleural effusion. Okay, everybody, is this clear? Don't miss left pleural effusion on an X-ray PA view. Few follow-up questions. Most sensitive investigation for any fluid, what does our thumb rule say? कि पानी देखना है, तो क्या देखेंगे? Thumb rule says ultrasound. So most sensitive investigation, ultrasound. If I tell you कि नहीं, मुझे X-ray ही करना है, which is the most sensitive X-ray as far as effusion is concerned, it will be And ipsilateral lateral decubitus. Ask the person to lie down on the side where there is effusion and you can pick up the minimum amount of fluid. Ipsilateral lateral decubitus. Alright, so 2 questions that you need to know. Okay, next image. What do we have here? Again, shortness of breath, history of trauma, unstable vitals. What is the diagnosis? Remember, when I say unstable vitals and when I say stable vitals, will give you two different answers. When I say that the patient is unstable, you will tell me, ma'am, this is tension pneumothorax. But when I tell you that the patient is stable, he has just mild chest pain and some dyspnea, you will tell me it is pneumothorax. It is not tension pneumothorax. So what is tension pneumothorax? It's a clinical diagnosis. It's not an X-ray diagnosis. Understood, everybody? How is it important? Does the management change? Absolutely. If the patient is unstable, tension pneumothorax, we need to immediately put in a needle. Next step would be needle thoracostomy, isn't it? So needle kahan pe dalenge? If it's an adult, according to the 10th ATLS guidelines, put it in the 5th intercostal space, mid-clavicular line. If it's a child, put it in the 2nd intercostal space, mid-clavicular line. On the other hand, stable pneumothorax hai. What do? No need to put needle. Go ahead with ICD. Where do you put ICD? 5th intercostal space, triangle of safety. Okay, is this clear? And will you stop in tension pneumothorax at needle? No. पहले needle डाल दो, फिर आराम से ICD डालो. Okay? Everybody, is this clear? This entire approach also we've done, but we've forgotten radiology like always. So what are we seeing? How to identify pneumothorax? We are seeing that there is this blackness, there is this lucency here in the outer part of the chest X-ray without any bronchovascular markings. Normal lung, bronchovascular markings. Here we have no bronchovascular markings, and I am seeing that this is the lung, this is the visceral pleural line, this is the parietal pleura, and there is air accumulated here. So the hallmark, identify lack of bronchovascular markings, identify visceral pleural line, and what happens to mediastinum, what happens to trachea, guys? It gets shifted, contralateral mediastinal shift. Okay, so this is how we recognize pneumothorax, tension pneumothorax, depending on vitals. Okay, next image. Again, very, very important images. What are we having? What is the modality? I am showing you ultrasound, M mode ultrasound, right? So again, for pneumothorax in EFAST, we use frequently M mode ultrasound. So what is the first M mode image showing? Lines, 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 and then beach, beach, beach. I am seeing a granular sort of appearance. So this reminds us of the beach. This reminds us of seashore. When do we go to beach? We go to beach when our lives are normal, right? So this is a sign of normal lung, seashore sign. It means that here you have the chest wall and pleura, here you have the lung. On the other hand, when you don't reach the lung, you only have lines because of pneumothorax. What is this called? Only lines? This is looking like a barcode or looking like space, stratosphere, right? So this is barcode or stratosphere sign which suggests a pneumothorax. Again, one-liner questions which are asked like ridiculous amount of times and we just can't get them wrong. Okay, all right guys, so this is M mode. Finally, two things that we've learned and we are now combining both of them. What is this? So this is air, black air here, right? So I'm having without any visceral pleural markings air, and then there is a horizontal level blunting of CP angle, means that there is a combination of water plus air, hydropneumothorax, right? So again, see my glass. What are we having? Is there air on the top? Yes. Is there water below? Yes. How? What kind of a level will it form when air and water are in a closed space? It will form a horizontal level. So can I say this glass is hydropneumothorax? Yes, if it was pleura. Okay, so this is hydropneumothorax where this horizontal air fluid level is key. If I see within the lung there is a round lesion with air fluid level, उसको कैसे बोलोगे? वो क्या बोलोगे? It won't be oblong like this. It won't be occupying the entire pleura. That would be our abscess. उसी air fluid level के साथ अगर मैं ऐसी क्रम्पली membranes डाल दूँ, it is not a horizontal air fluid level. It's like this. Then what does it become? it becomes hydrated, right? So are all of these DDs of air fluid level clear to us? Hydropneumothorax, abscess, hydrated, all independent questions in themselves. So these were the 10 images of the day, 26 minutes, fine, no issues. All right, so meant to be 15-minute classes, but as long as it's clear, it is absolutely fine. Okay guys, so see you all tomorrow 11 o'clock. We will meet again on YouTube. Fine, and I'll also tell you about the classes which are lined up from next week. So what I'm thinking guys, ki next week say we'll start our special classes from Monday. I'm planning one this thing, strategy class for INICT, and what will be the plan for the classes ahead on Monday night, and following that we'll be having daily 2 special classes, and we're beginning with rapid revision of different subjects. All right, so what we're going to start is what we're going to start is pediatrics. So now INICT is not very far away, right? It's very few days, and in between we'll have Diwali and stuff, and we'll need our breaks. So we'll start now, all right, and hopefully before your exam, INICT exam, will be done with most subjects. Okay, so we begin on Monday. All right, day after tomorrow. FMG students, this is for you, no? This right now what we have just done is for you guys. है ना? So don't be greedy. Every day we'll do something, and 2 hours every day I'm taking FMG classes on Plus. So join Plus classes. Every day 2 hours we're studying. Okay, so बहुत सारा FMG studies तो चल रहा है. Okay, बाकी अपन we'll continue. साथ साथ we'll keep seeing these images. Okay, so every day even if you study half an hour for radiology हो जाएगा नहीं? It will be enough. Fine. So don't worry, this will continue. This YouTube series is not going anywhere. Even if I start special classes, we'll keep meeting 30 minutes a day, 20 minutes a day. I think इतना radiology पढ़ लो तो बहुत है. Multiple subjects will get answered. Okay, ठीक है फिर. मिलते हैं. PDF has been posted on the Telegram group. The name is Radiology with Dr. Zainab Gora. ठीक है? Okay? Fine. Bye.